right. Well, this is unusual. You're coming to a talk about sudden cardiac arrest, and I'm going to talk about our experience with talking about sudden cardiac arrest. And so bear with me. I'm going to try to paint a story of kind of what happened in our community and what we've done, and I think hopefully what's happening here can happen all over the country. I'm always supposed to give financial disclosures, and I'll say nothing applies here at all. And I'll start out why we came together, and it's always sad when you have to have a bad event locally that brings people together. But as Charlene told you, the death of Wes Leonard, and we've been in constant contact with his family ever since, was just tragic for everyone involved. And it was another death, much like we heard before, that just didn't have to happen. And Wes died immediately after scoring the game-winning basket on an undefeated season, and there were about 2,000 people watching. And I'm sure every one of them would have loved to perform CPR and to shock him out of his life-threatening rhythm, but unfortunately no one did. And I don't think anyone didn't do this because of anything malicious. It was clearly people just didn't know, and it really got the community involved. From us, being in West Michigan, being very close to where this occurred, we immediately started getting calls, and these calls were from parents. Could this happen to my child? Were from schools. What should we do to prevent something like this happening again? There were local newspaper articles about this, and we all sat around and said, well, there must be something we can do to educate the community. And the first thing that came to mind is, well, it's very hard to screen, and I'll talk about this in a moment, but it's not so hard to perform CPR, and I can tell you that anyone can shock a patient. These new AEDs are amazing. These little boxes, you hook up some patches and you press a button and they literally talk to you. And so we started thinking about teaching people to do CPR, when to do it, and trying to get AEDs for the community. And then suddenly in our local paper, and this is the online version, there was a front page article talking about screening for sudden cardiac arrest. And actually, instead of interviewing someone here from University of Michigan, someone locally, there was interviews done with cardiologists from other parts of the state who were very much advocates for screening electrocardiography. And that really got us thinking, maybe is this the right thing to do, isn't it? And I'm going to talk a little bit, I'm going to paint a picture here and explain why I believe the AHA is right, at least with the current data. So first, and this is taken from the U.S. Department of Education, there are 17 million children right now in grades 5 through 8, and there are about 16 million young adults in grades 9 through 12. So if we add that all up, it's 33 million kids, pretty easy math, and about half of them play some type of sports. So about 16.5 million athletes, about 16.5 million non-athletes, whatever that actually means. And then that's not taking into account college students of various ages, about 18 million, of which a fair number participate in both organized and not so organized sports. So we're starting to talk about huge number of people if we're just talking about athletes, which quite honestly, I think all of us worry about our children and our neighbors and our friends, athletes or not, but still a huge number if we're just talking about athletes. And as was actually brought up from Barry Marin's very excellent database, we know about 66 athletes per year die suddenly, the average age being about 18. And the most common cause of death, somewhere between 1/3 and 40%, is hypertrophic cardiomyopathy, but there are other causes, such as congenital coronary anomalies, inflammation of the heart muscle, and there are a myriad of other diagnoses that can cause sudden cardiac arrest in the young. And this brings up a problem. So if we all will say that we now have many millions, tens of millions of student athletes in the country, and that of these tens of millions, about 66 will die suddenly per year, and of the 66 that die suddenly per year, about 40% of them have hypertrophic cardiomyopathy, there's a problem when you start looking at everyone's hearts. Why? Because people in sports exercise, and if you exercise about an hour a day or 3 hours a week, this can result in a normal enlargement and thickening of the heart, the main muscle, the left ventricle, and this may be difficult to distinguish between hypertrophic cardiomyopathy and some of our common screening tests, and this is called athlete's heart. To diagnose an athlete's heart, one of the common recommendations is that the athlete should not exercise for 6 months, and you look at their heart again. And if their heart gets smaller, it probably was an athlete's heart. Well, I think we would all argue that having people not exercise for 6 months is probably not good for those folks, and it's definitely not good for I have kids in school who play sports, and they would go crazy if I all of a sudden pulled them from their sports. So, and this is once again kind of leading into a picture, so bear with me for a moment. And so now we got to screening tests, and in Grand Rapids, where I live, there was big controversy whether there should be EKG screening, and I will tell you that there's a hospital in this side of the state that very much advocates for this, and another hospital on my side of the state kind of picked up and actually joined in with them, and we started thinking, maybe this is the right thing to do. It sure sounds good. You know, you can do tests on people and pick up bad things before they happen. The problem with EKGs, particularly EKGs in young children, is that there's a high false positive rate, meaning that you'll get an abnormal test, but actually everything is normal and fine. And actually, there was a recent study just published this year for pediatric cardiologists, where about 67% of them agreed on EKGs. So take a lot of EKGs, and even amongst the experts in the field, it's hard, especially when you talk about kids, to agree on what's normal and what's abnormal. And then you say, well, if you have an abnormal EKG, the next step is usually an echocardiogram, which is an ultrasound of the heart. And based on recommendations from boards that govern these things, a pediatric echo is a lot more complicated than the average adult echo. It takes about 45 minutes to obtain good images. It takes about 15 minutes to then perform measurements on 10 different functions of the right ventricle and left ventricle. And then you have to weight and age adjust it. So a 6-year-old has a very different looking heart and thickness of heart than an 18-year-old. And not to mention, on young kids, you try to see where the arteries of the heart originate. In older teens and the like, that's often very difficult. So the problems with this test, well, if you really were going to do a rapid screening test as an echo, you'd have to do it pretty quickly, and that would go against everything that was just recommended by the major boards that recommend this. And then you'd have to know all about the height and weight of the kid, adjust for this. And unfortunately, very often, particularly for hypertrophic cardiomyopathy, an echocardiogram of a 14-year-old boy might look totally normal. He might be genetically positive for hypertrophic cardiomyopathy, but very often this is not seen on echocardiogram for years later. So a normal echo might be very reassuring to a patient and his family, but actually might not offer any reassurance at all. And this doesn't even talk about the other 2/3 of causes of sudden death of the young. And finally, we have this whole athlete's heart issue to contend with. If there's a huge number of EKGs that will be abnormally read that are ultimately normal, leading to a huge number of echoes, you suddenly have a lot of kids that are pulled out of sports just waiting for their heart to normalize, and that would have deleterious effects on all of us. And going a step further, on an echo, especially in older kids, as I mentioned, you often can't see those coronary arteries, and that may lead to CAT scans or MRIs, which are either expensive or, in the case of CAT scans, submit children to radiation that it probably don't need. So now you're talking about doing tests that potentially could even cause harm for something that you might never pick up. So going back, why is this a big topic? Well, in Italy, they actually screen everyone with ECGs. And why do they do this? Well, in Italy, at least in my field, electrophysiology, they seem to do a lot of things that no one else does, and they have data that supports it. However, if you look at the data that supported this, the baseline period where they did not test people with EKGs had a very, very high rate of sudden death for a few years. This was much higher than in past years in Italy. Suddenly, they started doing EKGs on children, and their rate of sudden death went down dramatically. And when you compare the before and after, it looked like EKGs had a huge impact on decreasing sudden death. But if you were to compare just a few years before in Italy, it had almost no impact. You add to that in Italy, people die of different things. There's an entity called arrhythmogenic right ventricular cardiomyopathy, which is far and away the most common cause of sudden death in Italy. We just see that very little here, and it's something that you pick up very differently when you do testing in the U.S. And finally, in Italy, and even though they're now bankrupt or almost bankrupt at the time, they must not have been, because they have very expert screeners, and it's a 4-year screening process before you're allowed to perform ECGs in this fashion. In the U.S., it's nothing like that. In Israel, they actually have been doing screening for about the last 13 years, ECGs, and there was just a paper out this year comparing the past 13 years of ECG screening to the 13 years prior, and there was no difference in the rate of sudden cardiac arrest in the young. So that's pretty compelling data that while ECG screening sure sounds nice, it might not be the answer. And finally, in Denmark, they do no ECG screening, and much like everything in these countries like Denmark, they have less sudden cardiac arrest than Italy or Israel, who does all of this. And here, you know, we all know, and actually my wife's a pediatrician, and we talk all the time about the kind of physical exams that are done. And I remember when I was a kid doing sports, walking through that lineup where someone's listening to your lungs and doing your hernia exam and all those fun things. And maybe that is a problem. Maybe we need better screening, and actually we've been talking a lot about better history taking, and you can't take a good history in an assembly line physical. And so we come back to our original numbers. If we have 33 million kids in grades 5 through 12, approximately 50% of them play sports in high school, so you're talking about 16.5 million athletes. That would be 1,320 ECG screening athletes per day per state, and the rest of these non-athletes don't count. About 18% of these ECGs will be abnormal based on studies, and now you're talking about 3 million echocardiograms extra done per year on young athletes. That works to about 238 echoes per state per day. And the head of our pediatric cardiology department actually contacted a number of pediatric cardiologists in the state and kind of got a rough estimate that we currently do about 165 pediatric echoes a day in the state of Michigan. So you'd be more than doubling the number of echoes for a screening test that we're not sure if it actually helps. And then all these people you don't screen, not so nice. So I kind of like this one. Sometimes, even though it makes sense, and sometimes I'd like my kids to wear helmets every day so they don't hurt themselves, it's not always the right thing to do. And I'm going to show you a video of what I think the right thing to do is. So this was a 25-year-old professional soccer player, and this is just a kind of a hard thing to watch. So unfortunately, this CPR that you're seeing here, this is time delayed. This was markedly delayed, and this young soccer player died. And when you think of it, if you have something that is so rare that it is very hard to detect, and we have limited resources to try to do so, aside from doing things that make sense, it sure makes sense to us to try to act quickly when something bad happens. And this is something that I think every cardiologist is aware of, and probably everybody is aware of. The longer it takes to get effective defibrillation, meaning shocking the heart back to normal rhythm, the less likely you'll survive, period. Now, CPR can extend that to some extent, but not much. And at the end of the day, CPR is great. Getting shocked is even better. And the sooner you're shocked, the better you are. And what did we do about it? Well, with the permission of Wes Leonard's family, we decided that we'd do 3 separate things. The first was we started symposia on what to do for schools and what schools need to know, and we invited a number of, and I'll kind of skip through that, we invited schools in the area, athletic directors, coaches, school administrators to come. We described the problem. We described why screening might not be the answer. And then we had courses educating them on CPR, and we actually got a fair number of dollars donated. And to this point have, I'll kind of jump here, we've given over 50 AEDs to local schools, but not just handing people AEDs and saying, here, they had to demonstrate that they had an AED program, that they had a defibrillation program where they knew where they were, who was designated to use them, appropriate maintenance on them. The last thing you want to do is have an AED behind a locked door or an AED with a battery dead. What else did we do? Well, we decided that, actually, after talking to my wife, and she said, well, you know, I keep on getting patients coming to me saying, shouldn't you do more to screen? And we said, well, yes and no, and we decided we should do a forum for local pediatricians, family practitioners, nurse practitioners, and we did that in July, and that went over very well. We had about 70 providers come. We telecast this throughout the state. We had CME credit, much like you did, and we went over the new Michigan High School Athletic Forum, really focusing on history. And that went over very well. And what came of this, and actually it's ironic that you brought this up and you have so much experience, is that in Michigan, schools have to have 6 state-mandated fire drills, 2 tornado drills, 2 lockdown drills. How about sudden cardiac arrest drills? And this kind of gets to the point of it. At the end of the day, we need to know where defibrillators are. People have to know how to use them, and we really try to emphasize this. Having a big school, having a defibrillator in the gym, and having kids out on the football field or the soccer field, not so good. You can even go a step further and say that all of us in this room going to watch our kids play sports are the ones that are probably going to need to be defibrillated more likely than the kids anyways. So you can say this is selfish, but it's important. Our future plans, we actually next week have a large symposium somewhat like this for the general public talking about this topic. We're going to continue doing school and provider programs. We're going to keep giving away AEDs, and we've actually been in contact with a representative from the Michigan State House talking about mandating basic life support training for all Michigan teachers. And that's not my talk. So that is it. So thank you very much.